And we'll give people just a minute to get into the room.
Oh, shoot.
Hello, everybody, and welcome to this month's rendition of Stand Against Racism. We are here today to talk about maternal and infant health outcomes and the disparities there. I have a whole lot of things coming up on my screen that I don't know what they mean, so I'm just going to ignore them and hope that somebody else is taking care of it today. So welcome, everybody. Thank you for joining us here at YWCA on our mission to eliminate racism, empower women, and promote peace, justice, freedom, and dignity for all. I do have just one announcement before we get started. We have been working very hard. Some of our interns here at YW, particularly Melissa, who's our usual host, you probably see her name pop up sometimes, has been working on a report for the Brown County Health Department about health disparities and how racism is really impacting health and well-being in our community. And report outs for that will be happening soon. So the first will be an English-speaking report out that will happen Saturday, March 20th at 10:30 in the morning. And then additionally, we have Somali, Hmong, and Spanish report outs coming later in the kind of season. So to register for that or to find out more information, you can visit www.ywca.org/social-justice-programs, and you'll be able to find it there. So we would love if you could join us for that report out. Some really good work that has happened around trying to identify some racial disparities and how racism is really affecting health and well-being here in Brown County. So again, that is go to www.ywcagreenbay.org/social-justice-programs to find out more information or to register for one of those report out webinars. So again, thank you so much for being here, everybody. And we have a really fantastic panel today to talk about infant and maternal health outcomes and racial disparities there, particularly racial disparities affecting our Black communities here in Wisconsin. So first, let me introduce Jamila Seaton. Hello, Jamila, welcome. How are you today? Can you give us a little bit of an intro?
Hi, yes, thank you, Andrea. So I'm Jamila Seaton. I am currently a healthcare analyst at healthcare economics analyst with United Healthcare, but I did my master's in public health in epidemiology and biostatistics, which is where I started getting interested in health disparities, particularly with maternal and infant mortality rates in the Black community, started research focused on Hillsborough County in Florida because at the time they had one of the largest disparities in the country, and have continued my interest in the topic.
Thank you so much for joining us. We're really excited. Next, we have Dr. Shree. Can you give us a little bit of an introduction?
Yeah, thank you, Andrea. My name is Dr. Shree. Shree Narasimha is my full name, but I go by Shree, obviously, for it's easier. I've been in practice for about 20 years. My training was I did my residency training at Washington University in St. Louis, and then practiced at the University of Texas Southwestern Dallas and Parkland Hospital. The very large, racially diverse and ethnically diverse communities and very large volume obstetrical population. And then after that, I've been in the Fox Valley area for about 13 years. And affiliated Theta Care, as well as most recently now also doing some shifts with St. Joseph Ascension Hospital in Milwaukee. So a predominantly Black and African-American population there. So I've kind of seen the gamut of the large population in different areas of the country as well.
Thank you so much for joining us and for being here today. And last but certainly not least, we have Dr. Shilpa Ullikashi.
Hello, thank you, Andrea. Hello, everybody. So I'm Shilpa Ullikashi. I have joined as a pediatrician in Preview recently. So I just finished my residency in pediatric last year, and I'm very happy to be in the talk today. So just a little bit background about me. So I'm from India. So I had done my residency in OB, and then I moved from maternal care to child care, and I'm enjoying it. Yeah, I have the racism has always been a topic of interest for me, and now that I'm a practicing physician, I happen to see that, and yeah, I'm very glad that I'm here.
Thank you so much for joining us. So for you out there in the universe watching, you can see we've got three really different perspectives on this, from more of an epidemiology and statistics kind of a perspective, and then OB and maternal and actually having babies, and then into kiddos and taking care of babies on the other end of that as well. So we're really excited about this. I do want to give one huge shout out to our community services committee here at YWCA as well. They do a tremendous amount of work getting our panelists together and planning all of these. So thank you to all of our community services people out there from our committee. All right, so let's get started. Jamila, do you want to kick us off with some info?
All righty, sorry. Confirming that you can see my screen, hopefully. Okay, great. And in presentation mode. So the reason maternal and infant mortality rates have been an interest to me. So over the past years, we have seen that the Black community has seen, we see significantly higher rates of mortality in Black families. So in the US currently, the maternal mortality, pregnancy-related mortality ratio, which is used to estimate maternal mortality, is significantly higher for non-Hispanic Black women than any other race, followed by our indigenous populations, as you can see. And then Wisconsin specifically, although Wisconsin's pregnancy-related mortality ratio is typically lower than the national, we actually see the largest disparity between non-Hispanic Black women and other races in Wisconsin compared to the rest of the country. And so it's about 5 times higher in Wisconsin and about 3 times higher than the rest of the country. It's a very similar story and an even greater disparity when we look at infant mortality. So nationally, we see that the infant mortality rate for non-Hispanic Black infants is about 10.8 compared to other races. We see that the next highest is 9.4. And in Wisconsin, though, our infant mortality rate for Black infants is 15. And then, so that's even higher than the infant mortality rate for Black infants outside of Wisconsin. So how did we get here? I'm going to talk a little bit about the history and then kind of talk about where I think solutions lie and where some of the issues have been. And so from a public health perspective. So we do know that when it comes to reproductive health, we've seen some unethical things. Dr. J. Marion Sims, who's considered the father of modern gynecology, while we learned a lot about reproductive health from him, he conducted his research on enslaved Black women. He didn't believe that Black people could feel pain. And then going into the early 1900s, we start to see where forced sterilization was incorporated into law, and that led to Black communities, people of color, people with disabilities started to be targeted, and this was legal because this was incorporated into policy in 32 states, Indiana being the first. I like this graph because this shows North Carolina sterilization rates, because we actually see a spike in Black women being subjected to forced sterilization in the 60s, or in the late 50s into the 60s. And this was during desegregation. So when we saw this rise in civil rights, a time when the US was unpacking a lot of its racist history, we see this increase in forced sterilization. Then we have stories like Henrietta Lacks, who is being treated for cervical cancer at Johns Hopkins and Johns Hopkins at the time was one of the few institutions that actually treated African-American patients. But even in that setting, we see that vulnerable populations were still exploited. So her cells were harvested without her knowledge. They're called HeLa cells, and they've been breakthrough in research, but her family was researched without her consent, without her knowledge. She did pass away during that time, but her cells have been incorporated into research even through the 70s when her cells were being used in some major projects. Her family still was unaware that the HeLa cells were taken from her. So these kinds of things create a lot of distrust between the Black community and the healthcare and the healthcare system. And I want to talk a little bit, why do disparities matter? Because some people think, well, someone has to be the worst, right? Somebody has to be somebody's going to finish last. Well, they matter because it costs us. Cigna has done an estimate that it costs about $309 billion. It costs the US about $309 billion a year due to health disparities. And so it's actually costing us resources, because when populations present with more complex, more severe cases, that means we have to allocate resources to address those cases. We have to keep in mind that race standalone is not the cause of health inequities. So the reasons for these disparities are external. It's because of environmental factors, it's because of stress factors, it's because of other things that race is correlated with. But standalone, Black infants aren't dying because of their Blackness. We have to think about the fact that solutions benefit everyone. If we address barriers to care for the Black community, we're addressing barriers to care, period. That means we're increasing access for everyone. The reality is we're becoming more diverse. And so we can't shy away from understanding what's going on in other communities. And then a pandemic like COVID not only sheds light on health disparities, but we suddenly have to take into consideration how every population is doing if we're going to measure when we've reached a place of safety, when we've reached a place of stability. Everyone plays a role in how our economics work and how our societies work, who our essential workers are. And so we can no longer, we've been forced to address health disparities a little bit more. I think some important things that we need to do are equip our medical professionals, making sure that our medical professionals are aware of what affects our Black communities more. So being aware that Black mothers may suffer more from preeclampsia, being aware that Black infants tend to be more compromised. And so we need to make sure that our medical professionals are aware. We need to make sure we're promoting prenatal care. Again, when we benefit Black communities, we benefit everyone. We need to be talking about financial support, and we need to make sure that we're being honest about our history and confronting racism. So when I talk about forced sterilization in the 50s and 60s, we're not talking about hundreds of years ago. We're talking about fairly recent. Women who were subjected to forced sterilization are still alive and part of the patient population. Our current providers, potentially trained by providers that conducted forced sterilization, the impact on those families is still ongoing. That trauma is still existent. And just thinking about how we've created our healthcare system, we were intentional in incorporating racism into our policies and into how our systems have been developed. So we see these disparities and know that our Black communities are suffering, and we need to be intentional. And when I think about our medical professionals, again, being aware to countless personal stories and stories that we read where medical professionals are sometimes genuinely unaware of the disparities. So something like fibroids that impacts Black women as tend to impact Black women differently. A lot of providers are unaware of that, and our standard treatment protocols don't incorporate any kind of screening for that. So we need to start being intentional about that. There are things that we can do policy-wise. I know there's the Maternal Care Act that has been proposed in Congress that starts to incorporate some of these things to making sure that we're equipping our medical professionals. So that's just a high-level overview of where we are and why this is such an important issue and some of the things that we can do to move forward. And I will pause there so that we can get our maternal insights and infant mortality rates in, and then we can come back together for the Q&A.
So thank you so much for doing that kind of history and level setting piece, just to make sure that we're all kind of on the same page here, that this is very real stuff that actually exists, and that there are very real causes, and it's not just skin color that has caused this, but there are these systemic pieces that have created this system in our country, and here in Wisconsin and here in Green Bay as well. So thank you for getting us kicked off, Jamila. So Dr. Sri, do you want to talk a little bit about the sort of the more maternal side of things?
Sure. Just again, the technical part, let me share my screen. Do you know, like when I share, just a quick question, when I'm sharing my screen, can I just get on, is everybody able to see that?
Yep, everybody should be able to. So the little green thing on the bottom that says share screen gets on. While Dr. Sri is working on that, I want to encourage everybody out there in the universe, if you have questions, if things pop up, please do use the Q&A function, which on the bottom of your screen, it says Q&A, it's got small speech bubbles, and we are happy to take some questions. So please do use that if you've got questions throughout the presentation.
Okay, so everybody's able to see this. I'm going to just talk first a little bit about the definition.
Yet, Dr. Sri.
You're not able to see it. It's loading. I don't know if it's. I'm sorry for the technical difficulties, but when I'm trying to share, it just says to share with add people or groups is I don't know.
Oh, so here on your Zoom window where you can see all of us, down on the bottom, is there a green thing that says share screen for you? Oh, so you're muted now.
Okay, so I have share screen.
Yep.
All right, I've clicked on that.
Yep.
And then it gives me some options, but I have I don't know exactly which window I'm supposed to pick to share here.
Whichever one has got your slides on it.
Presentation. And that's the thing. I have it open on another tab on the computer. Is that what I need to have?
Yeah.
But I'm not able to pull that up.
Yep. So you'll want to pick whatever screen it is that you've got and then go over to that tab. Oh, we see something. We see, yeah, click on that one. There we go. We see it now.
Okay, now if I hit the view, you're still able to, or if I hit present on that, you're able to see it. Yes?
Yep, we see it. It looks great.
Okay, sorry to waste that time. Okay, I'll skip through this. Okay, so I wanted to define when we talk about mortality and morbidity. Mortality means death. The World Health Organization defines maternal death as that which occurs within 42 days, and they say termination of pregnancy. Now, I want to make this clear. That means pregnancy that could end in a miscarriage or could end in a live birth, preterm birth. So it's in that 6-week time frame that we all think about as the postpartum time frame. But there is also what's called late maternal death, and that's outside of that 6-week window, but less than that 1 year. And this data that we collect on mortality comes from death certificates from each of the individual states. But until 2017, there wasn't a pregnancy checkbox on all of these states. It wasn't required. So some of that data was missed, but now it's a required portion. And the data that we might have from 2017 can differ from 2018 onwards. Maternal morbidity refers to illnesses. So it may or may not necessarily, it could be a mild illness or a severe illness. And this morbidity has a fine line to become mortality in some cases. So it's any health condition that can be attributed to or aggravated by pregnancy and can have a negative impact on the woman's health or well-being. I'm not going to read all of these here, but these are some examples of maternal morbidity. So maternal illnesses. And I want to point out a few of these. Hypertensive disorders of pregnancy. So high blood pressure pregnancy, preeclampsia in the spectrum, because preeclampsia has significant effects on mom and baby. Not only does it mean decreased blood flow to the unborn baby, but also decreased blood flow to many vital organs in mom at the most severe cases, to the brain, resulting in eclampsia or seizures, cardiovascular effects to the liver, to the kidneys in the mom. So very severe, and as Jamila pointed out, and we'll look again too, higher predominance in the Black population. Hemorrhages, infections, wound problems, cardiovascular problems, diabetes, pre-existing diabetes, again, Black population, higher rate of pre-existing diabetes, which then further gets complicated in pregnancy, complicating not only maternal health, but fetal health. Blood clots, this could be in the lower leg or to the lungs, amniotic fluid embolism, anesthetic complications, and any trauma from delivery. Again, reiterating what Jamila pointed out to us, that Black women are disproportionately affected with this maternal mortality rate. This is from 2018, the National Center for Health Statistics, and it shows how, the bar right there on the left-hand side, how it compares to non-Hispanic white women and Hispanic women. That's not the only ethnic populations, but just 3 of the major ones. Highlighting that even further is this graph, which shows how this compares to the national average. You can see that what is bringing up the national average is unfortunately the Black women's population death rate. And this is per 100,000 live births, approaching in 2018 data 37.1, data before that 40.1, so where the national average is hovering around 17.5. Some maternal complication rates, preeclampsia, according to CDC, Black women 14.4% compared to Hispanic 10.9% and white population 9%. Preterm birth, which our Shilpa will get into a lot. Black women have a very high rate of preterm birth, which leads to maternal complications and obviously infant complications too. What I wanted to point out here is the stillbirth rate. This is a baby that is born that could have survived outside of mom, but had died in utero, so inside mom. That is a devastating thing for anybody. Black moms are twice as likely to experience a stillbirth than a white woman or a Hispanic woman. An underlying health condition is listed 3 times as often as the cause. So there are devastating results of these things. This data, although it's older, from the 1990s to 2008, I put on because its trend has not changed over decades. Here, the dark blue, you can see that African American women, their population always consistently higher for infant deaths, maternal deaths, preterm birth rates, and very low birth weights. That means probably babies that are born extremely preterm or were born maybe not preterm, but had growth restrictions. So every time throughout the decades, every single decade, they are always in the high population. Now, this little poster is put out by the CDC. It shows what are some factors associated with preterm birth. We'll take a look at that. One says Black race on there, but look at the other factors on there. Sometimes it is the Black race that are also subject to have some more of these factors. Lower income population, prior preterm birth. Well, if you are Black and you had a prior preterm baby, now you fall into this category too. Well, all of the socioeconomic factors that are negatively impacting the Black population then can create more issues. Stress. Well, then people who have stress are at higher risk for substance abuse. It becomes a vicious cycle. We have to break that cycle. No mom should have to deal with a preterm baby like this. Should be holding that baby in their arms. Here, this baby is requiring, oxygenation, has to be, is intubated, has multiple lines, IV access. This is not a pleasant situation. Look at this, extremely preterm birth. This is devastating to anybody, any mom, even who has all the resources. Then think about if it was a mom who has limited resources. Do they choose between being with their other child at home, going to their job, or being here with this preterm baby? That's not a choice that anybody should have to make. So there are many factors that contribute to disparities, and I'm not going to go into them into too much detail. But obviously, the discussion we can, and Jamila, I think, touched on a lot of these things. But what I want to mention is that racism is often overlooked. So these factors that we have, poverty, access to healthcare, education level, socioeconomic status, do have significant impact. But there is what implicit racism or bias is also affecting how medical care is delivered. Let's talk about Serena Williams. Serena Williams, famous, picture of health, wealthy, educated, a model for a lot of girls and women. Her story, though, is very harrowing. She describes in 2011, she was diagnosed with a condition that increased her risk for blood clots. In 2018, she had her baby girl. And shortly after delivering her daughter, she was feeling short of breath. So, and the shortness of breath progressed and she was getting more anxious. She called her nurse in and told her nurse, please call the doctor. I think I'm having a pulmonary embolism. Serena is well educated. She knows the risk of blood clots, and the pulmonary embolism is a blood clot that's gone to the lungs. Her nurse, she felt, poo-pooed her concerns, said, oh no, you're just tired, you're just anxious, don't overreact, and dismissed her. She persisted. She's like, no, please call the doctor. After insisting several times, doctor was called, and they ordered a lower extremity Doppler, which is looking for a blood clot in the lower legs. It's common that's a more common thing that can happen. But Serena, being educated again and knowing what was going on and being proactive about her health, said, this is not what I need. I need to cap my lungs and I need to be on a blood thinner. With her insistence, subsequently, that's what she got. And lo and behold, when they did her CAT scan, they found not just one clot, but multiple small clots throughout both lungs for her. But her story doesn't end there. So she got on the blood thinner, she got the CAT scan, and she got on the blood thinner. But her shortness of breath and her blood clots had progressed so much, she was coughing a lot. It ripped open her C-section scar. And because she's on the blood thinner to help gut the clots, she started bleeding and needed to go back to the operating room. This was traumatic for her. But think about this. This is Serena Williams, famous, educated, had to insist on this care and had to insist to get these things done. She has now become quite an advocate, and hopefully, we'll all learn lessons from this. My point here, though, is education level is not the sole cause for disparities. There at times are implicit bias and racism. Several studies have studied this education level, and in New York City, where their rate for maternal mortality is 1.6 times greater than the national rate. That's really high. They did a study where they stratified and took education, poverty, obesity, several other risk factors, and set them aside. And they still found that Black 3 times higher rate of maternal mortality, of maternal death. There clearly has to be something else going on. Take a look at this graph. here we have white population represented by the blue, African American population represented by the purple, dark purple, and Native Indian, Alaskan Native represented by light purple. So a less than high school education for a woman, the Native Indian and Alaskan Natives have a higher pregnancy-related death rate per 100,000 live birth rates, but followed very closely behind by the Black population. High school the Black population has a higher death. Some college or higher education, Black population always is higher. So it doesn't matter if they're educated, lower on the education level, less than high school, there is something that is still going on that is making this giving this disparity. So I cut into too much into our next speaker's time, but I'm just going to go briefly through a case study here. So Ariana is a 25-year-old, and this little abbreviation we here have is Gravida 2, Para 1. So Gravida 2 means she's had 2 pregnancies. Para 1, she's delivered 1 child, so she has 1 child at home. She's 35 weeks pregnant. So as an OBGYN, anything between 37 to 40 weeks is full term. So Ariana's a little early yet. Her history is notable for preeclampsia with her last pregnancy, and she was delivered prematurely for this. So her blood pressure was going up and unsafe regions, and so she had to be delivered early for this. So she already has a risk factor. She presents her doctor with complaints of fatigue and feeling unwell. She's missed 2 routine prenatal visits, but otherwise she has been getting prenatal care. So her doctor notes during her interview that she's a smoker, but she's cut down during the pregnancy. She works in housekeeping. Her blood pressure is mildly up and her are mildly swollen. So during the visit, her blood pressure is checked multiple times over a period of an hour. They remain in the mild range. Now, just for a reference point, pregnancy blood pressures are different than non-pregnant people. Most of us would say, oh, blood pressure of 135 over 90 is okay, or high normal, or in that range. But for pregnant women, they're usually in the 90s to 100s. So her blood pressure, is in the mild range. When we say that, means it's not necessarily totally normal, but it's kind of at that borderline range. She gets fetal monitoring. That looks good. She's advised, go home, take off of work, put your feet up, keep your appointment in 1 week, and quit smoking. All right, and then she's sent on her way. She returns before her visit in 1 week, and she says same sort of complaints. Now she's continued to work at her job. Her blood pressure this time is high, 160 over 105. So they observe her, and the pressure improved to 140s over 30s. So it's now in the maybe upper limits of normal range for her, but and the labs are normal again. So the doctor says, well, you can stay overnight in the hospital for observation, or we can send you home and you can keep your upcoming appointment because it's coming up. It's not too far off. I think, and they think that the initial blood pressure might have been, you just came from working a 12-hour shift. Well, of course your blood pressure is going to be up. If you're up walking, really active or stressed, that can send your blood pressure up a little bit. Well, Ariana says, I want to go home because of childcare issues. So she goes home. Her appointment is coming up this week. One day before her scheduled visits, she arrives by ambulance to the emergency room. She's found conscious. It's presumed from her exam and history that she had an eclamptic seizure. So preeclampsia can, as we said, get severe and result in seizures for mom. So decreased so it's progressive. She's postictal, meaning that after seizure, people are kind of confused and they can tell, okay, that's what's going on. And her blood pressure was 180 over 110 on arrival. Well, her preeclampsia is eclampsia and it's very severe. So they check the baby out and they find that the heart is very low, normal. She's now delivered by an emergency C-section. Her baby went to the neonatal ICU, and it's a little too early to say, but it's likely that her baby may have long-term neurologic injury because she had a seizure, a prolonged seizure, and remained unconscious and did not receive for a period of time. And that means that there was low oxygen to not only mom, but to baby. And subsequently that results in brain injury, what we call hypoxic ischemic encephalopathy, or just low oxygen to the baby. Ariana, however, herself, because she had an emergency C-section, they didn't have time for the spinal or epidural. She had general anesthesia. And one of the things that preeclampsia can do is cause pulmonary edema, lung damage. So she cannot move from the breathing apparatus at this time. So just briefly, I want to say, what could have been done differently? Were there assumptions made at her first? Did we let it go home, take off, put up her feet, take off of work? Could she afford to be off of work? Smoking. Well, is that an easy thing just for somebody to say? Or how hard is it to actually do that? It's almost like telling somebody lose weight, but not give them instructions. What would have prevented her from following her doctor's advice the first time? Would you know if she had childcare for her child at home? Would she have been able to take off if she wanted to? Does she have another supportive person at home? Maybe she's a single mom. Had she been hospitalized the second visit, could this have been avoided? It possibly could have, because preeclampsia is an evolving thing, and what you see one day or even in an hour in a mom as it becomes more severe may change. Could have been picked up sooner. What other information may your doctor not have obtained that could have affected her care? There are many things that were not assessed here. Offering her to go home and come back, was she even asked how easy is it for you to get back here for your appointments? She missed 2 prenatal appointments, but had been getting prenatal care otherwise. Did she take the bus to get to her appointments? How does she has to leave work? She probably works during the same hours that the clinic is open. Then the clinic closes. How is she supposed to get to emergency care? These are things that we have to acknowledge. And if there is, that are barriers to care that are possibly rooted still in some racist tendencies as well too. And just briefly, what can we do to improve? I think Jamila touched on these already, but one of the things is increased awareness, but support public policies that remove barriers and advocate safe and healthy living environments for all groups, and standard protocols, especially for communities that are at risk, so that you are going through a checklist to make sure you've addressed all these things. Basic needs have to be met in order for you to be able to even meet those recommendations made by a physician. We should recognize that there's racism, institutional racism, and stereotyping all negatively affect healthcare. It's not enough for us as a physician to say, oh, that's just higher in the Black population. That's just the way it's going to be, that particular condition. No, we can't continue to do that because we're never going to move forward. And we have to be aware of our implicit or unconscious bias. It'd be a topic for another whole session, but there have been studies in which people have not been aware that they actually have their own implicit bias in taking care of patients, and say, well, no matter what I do, they're still going to do the same thing anyway. They're still going to have that same risk. We cannot keep doing that. We have to ask and assist, remove those barriers, and remember that it's not just education or a lack of wanting to improve people wanting to improve their healthcare. There are many other factors that we have to all address on a basic level, both medically as well as on a social level and within our own policies. And that's
Thank you so much for that, Dr. Sri, and that more maternal perspective on things. Dr. Shilpa, do you want to take us next with the more infant perspective?
Yeah, sure. Share my screen now. Hopefully it's easier. Okay.
You see that green arrow down on the bottom?
Yeah, I'm able to see that.
Okay.
I'm sorry. I'm sorry again.
No worries. All right, so that green arrow down on the bottom, and then choose what screen you want to share.
Yeah, it is asking me so many options again. So I'm just saying, oh, gosh. Portion of this. So are you able to see now?
We're not
Yeah.
able to see yet.
Oh gosh. So it is asking me basic, and it is having different, like, options here.
Mm-hmm.
Desktop, iPhone, iPad, and all that.
Yep. So whichever screen where your presentation is. So
Yeah,
probably your desktop.
Yeah. That's what I'm trying. It's not. Oh, okay. Jamila, I have my presentation with you. Can you open that for me, please?
I can. I will go with that.
Yeah.
Yep. Do you see email? Yeah. From the.
You can just open from your screen. I think, again, I don't know, checking the email, and it may take time. I'm sorry for that.
No worries.
Yeah.
Download. Okay. Yep, I have it, and I can.
Yeah, you can
share for you.
Yeah. Thank you so much. Thank you. That's good that we
We're a
shared.
team. We need all parts of the system
Yeah.
working together, and
True,
so
true.
we are demonstrating that. Okay, so I will. Share, and then I will. Sorry, I'm gonna present.
Okay, so this is just an introduction. The next slide. So this is again, before starting about infant mortality, I would like to have a definition be clear to everyone. So basically the infant mortality is defined as the death of an infant. Infant is is a baby which is less than 1 year old. So that is like before or her first birthday, if the death occurs, that is infant death. So the infant mortality rate is a number of infant deaths for every 1,000 live births. That's how it is defined. Next slide, please. So this is again, Jamila has already mentioned about this. She had a slide. This is again from the CDC. So this bar chart presents the different infant mortality rates based on the race as well as the ethnicity. So if you see here, so it is highest in a non-Hispanic Black population, and then the indigenous American, it's still higher compared to the other races. Next slide. So this is the same data, but put in a different style, again, highlighting that it is more common in the Black population. Next slide. So again, as Dr. Shri was mentioning, the causes of the maternal mortality and how they can lead or affect the infant. So here is what we were talking about. So these are the leading causes of infant mortality. So very common ones are low birth weight. Again, this can be due to preterm baby or small for gestational age baby, or the baby which has not grown to the enough weight required for that gestation. And then congenital anomalies, most of the time it can be prevented, like a neural tube defects, if the maternal care is good, but some of the genetic factors are not in our hold. And again, as it was highlighted in the previous talk by Dr. Shree, maternal complication plays a very important role in infant mortality as well. So if you see the chart here, so if you see the death rate among African Americans, so it is 83%, whereas if you see the non-Hispanic white, it is 23. So there is a significant difference between the races here. And then the other causes like accidents and sudden infant death. So almost all the death rates, whatever the cause be, it's more seen in African American population. So it means that there is a disparity. And again, I'll be talking in my further slides why this can occur. So now we are in the COVID area, and so I just wanted to put a small chart here to see, to show you all that, yeah, this has affected, in fact, it has widened the gap in the disparities. So the first one, what you're seeing is 7% is about the white children who were tested for COVID, but when you go down, it is much higher in the non-Hispanic Black as well as the Hispanic children. So there is quite a bit of disparity. So next slide. So this is like a social determinants, which can, to some extent, help us to understand why this disparity occurs. So first of all, everything comes with regard to the adults who are taking care of the kids. So the place they live is very important. Again, it will be related to poverty, the food insecurities, whether they are able to provide good food for the kids or whether the good food for the mothers who are pregnant or taking care of the kids, and legal assistance, because many of the studies have shown that these basic needs are to be met if you have to in fact, I would like to say that the longevity is dependent on these basic needs are met. And again, the access to safety net hospital, community centers, and even if they're there, whether they're eligible for Medicaid, whether the workers there, the providers there have a culturally appropriate uh, manner to address the issues with the population serving the area. And again, very important is housing as well. So there is a small figure where you can see that on very end of the left side, you can see that education, employment, income, and poverty, these are the main social determinants. And these are kind of amplified by the racial bias. And these factors, though, this affects different factors of life, which can lead to infant death, mortality, morbidity, not only in infants, even in the adults or with the Black population. Next slide. So again, this has already been touched very nicely by Jamila and Dr. Shree. So why these disparities are there? So these are the product of possibly a lot of like, you know, in the past, the policies and practices which has widened the gap in education, income, opportunities, and which has led to the downtown, or, you know, like downtrend in different populations, especially in the Black population, where there is less access to the basic needs and leading to the health disparities as well. So again, this has come, which we have already talked about, distrust in the healthcare system. Again, this is because of the past history, the syphilis study, the tuberculosis outbreak study, and again, Jamila has very nicely talked about Sims racism. And the last one, so this was a study which was published in the pediatric journal. So this was a just a data collected from children and youth who with the sickle cell disease, which is more commonly in African people. So this was a study done in a ED. So basically, they collected the data from these children, asking about the pain perception and what pain medication they received. And it was seen that the Black children had received less suboptimal dose of medications. And many of the children said that their pain was not well controlled when they were sent home, because
as I think Dr. Sim had done few studies in children as well, and he had always had a perception that Black population have a less perception of pain, which is totally wrong. And so I see that in this study, the kind of similar perception which is there, which the provider may not have been aware of. So yeah, these all are the disparities which are there. Now, this is the important thing which I want to talk. Why it is very important to address racism, especially in childhood. Many studies have shown that that constant toxic stress, because the racism has been identified as a social determinant of health, this can lead to change in molecular, cellular, and behavioral level in children. And it has shown that 6 or more adverse childhood experiences can cut down the longevity as much as 40 years in a child's life. Again, you don't want to keep changing yourself to please the world, right? So that is known as internalized racism. So here the kids, especially the adolescents, because they have been reinforced by the surrounding adults and the other people, the society, the community, they start having a inferior complexity, and then they develop a desire to change. For example, here, like straightening the hair. So this is one of the example, but yeah, there are many changes with especially the adolescents can go for. Next one. So as a part of pediatrician, it's my duty to make sure that I address and keep our kids safe and help the parents help in taking care of kids in a right way. So these are anticipatory guidance. So when you see in the preschool between 3 to 5 years of age, the kids start noticing, especially they start asking the color of the skin, why it is so different. So in that age group, it's very good to address by reading books or, being in multicultural groups so that they understand the importance of uniqueness of each self. And then again, early childhood, again, it's a very best time to talk about racism and have a very healthy discussion and know their thoughts as well. Again, this is policy statement which is available in our pediatrics, that is AAP from American Academy of Pediatrics. So here we make sure that the trainees have been trained well in terms of facing different people of different races in the practice. And again, equal opportunity is given to identify the stressors or any health needs and indifference in putting the referral services as well. So whenever a family, especially coming from a lower socioeconomic background with a Black community who has faced racism, it's very culturally sensitive issue, needs to be addressed in different forms, like referring to proper resources to help, for making sure the education is well met, and giving good support of addressing the food insecurities as well. So these are few of my references. The next one. Yeah, thank you. I'm sorry for taking a little more time and technical problems. Okay, and together I say we should stand to stop racism.
Thank you so much, Dr. Shilpa. That's really very helpful. And to see this from kind of the 3 different places and where they merge in this infant and maternal morbidities and mortality rates and how those are different. So we really appreciate all of that. Dr. Shilpa, I also really love that you sort of came out and said it, that there's all of these pieces and you have this graph or this, this graphic, right, of racism affects all of these things that cause more stress, but then also really just coming out and saying racism causes stress and stress is bad for moms and for babies. Right? So I really appreciate that. We do have a question in the chat, if we can address quickly, about how to really build a NICU program and maternal and infant and fetal health program that's going to address some of these disparities and make sure that we're really appropriately taking care of everybody in our region. Any thoughts about that one?
Well, I'll just say quickly from a public health perspective, some of the things that come to mind that we talked about is making sure that all staff, everyone's trained around unconscious bias and cultural competency, making sure that your resources, that you've done that research around the resources needed for the community that you're serving, and just making sure, as we talked about advocacy, that Black women and Black families tend to be their own advocates. And so we need to make sure that everyone is being an advocate for our Black communities. So, so just making sure that you have the resources, not just the materials for actual practice portions, which I depend on our doctors, but just in terms of incorporating social services resources and those kinds of things into your protocols and your family management, because we have seen intervention for mortality rates be related to those kinds of being able to resource families properly. So those are just some of the things that are coming to mind. And we do know that I'm thinking of some parts of Florida. I'd have to do a little bit more research, but even with Hillsborough County, I know they have actually seen that disparity reduce. So could probably follow up a little bit on some successful programs that would be helpful.
Can I just add that one of the things that, like Jamila said, resources, is that our social service workers are overstressed. I think in the hospitals, there's like one social worker and tons of patients that particular person might have to see. Now in the NICU, I think every baby before I go home, they have some hospitals, and most hospitals now have established that there is a social services assessment or consult, and because they want to make sure NICU babies do go home with some special needs, still attention, they do that. But there are still moms who maybe their baby doesn't go to the NICU, but needed special care and was in the special care nursery or just even went home at term, but then there's readmissions that occur because at home maybe their baby wasn't gaining enough weight, et cetera. I think it would be great if we could have public policy where every patient, regardless of race, socioeconomic level, all had a social service assessment worker. And it wasn't just as a check-off box because the social worker has 50 patients to see, but it's actually because there are enough workers for each case. For that volume hospital, they have the right number of people, and it is actually a true assessment and a follow-up, because we see patients, the baby delivers, if everything goes well, they're in the hospital for 48 hours, 2 days, and now with COVID, it could be even 24 hours, then they go home. What happens once they go home is a huge impact, and what happens before they even come into the hospital is a huge impact. So it's those things, if we could have those resources, have enough social workers to even link people up to their resources, would be great.
And here I like to add one more thing. It's always good to conduct some internal quality analysis to see satisfaction of the patient satisfaction in terms whether they were addressed appropriately, whether proper protocols were followed, which were addressed during the admission. Maybe that kind of feedback from the patient perspective can also help in improving the gaps and addressing the issues which are there.
To go along with Dr. Sri and the comments that you made about having enough staff, from a social justice perspective and an anti-racism perspective, particularly in the implicit bias kind of piece of things, we really see that implicit bias comes out when people are, going from thing to thing, going from task to task, going from mom to mom and baby to baby all day long, and not really having a chance to stop and take like a good deep breath and like refocus that like here we've got a new person, we've got a new kiddo that we need to think about. So having staff that is able to be really fresh and really work with each individual person and mom and baby, instead of just kind of rushing about and treating people as more numbers is really helpful. And also we see huge racial disparities come out in lots of different kinds of fields after people have worked for a certain number of hours. So scheduling people for 8-hour shifts is really helpful in that. We find that after those 8-hour shifts, implicit bias comes in much more strongly for people. So being able to do that and schedule people appropriately so that they can focus and live in the front part of their brain where they have moralists and ethics and planning and values and all of that kind of stuff, instead of living in more of the back part of their brain where it's just sort of fight or flight and survival kind of mode is really very helpful in that. So any other last thoughts from y'all before we move on? Anybody want to say any last thoughts?
I mean, I'll just say, because it is near and dear, and a quick shout out to Dr. Shri, just thinking of, when I said personal stories. So, my sister was given advice to not go to the ER when she was pregnant and and she ended up she had complications. She decided to go against the advice and was admitted and had complications during her birth. My friend just last week, she's a nurse and post-delivery developed preeclampsia. And so myself, not maternal related, but reproductive health with fibroids, I had a practitioner say, oh, fibroids aren't a big deal. I'm sorry that you're in pain. Not much I can do for you, until I went to Dr. Shri, who immediately said, of course you're in pain, and kind of followed up on that, aware that Black women tend to present with more complex cases. And my point is, believe Black women. So really, I'm sure as doctors and medical professionals, and sometimes in other fields, no one wants the person coming in who's Googled their symptoms and is coming in trying to be the expert, but making sure that you start off with believing your patients, believing Black women, and then incorporating those other things that you can start. You will find the evidence to lead you to where you need to go. But too often, because our protocols don't necessarily incorporate those disparities and those presentations of more complex cases, that is a huge part, I think, that starting point. So I just want to say, believe Black women.
Well, with that, that's a fantastic sort of end to our panel today. So Dr. Shri, Dr. Shilpa, not doctor, but MPH Jamila, thank you so much for being here with us today on this panel in this really important topic. Again, out there in the universe, I invite you to participate in the YWCA report out on health disparities and what racism is doing for health and well-being here in the greater Green Bay area, coming up on March 20th. Again, you can register and find more information for that at ywcagreenbay.org/social-justice-programs. Those dashes are really hard to say out loud. To find more info and to register for that. Again, thank you to the panelists. Thank you to all of you out there in the universe watching and joining us in our mission today to eliminate racism, empower women, and promote peace, justice, freedom, and dignity for all. Thank you so much and have a great day, everybody.